Hello, everyone. Welcome to your Phase III clinical trials lecture. Again, I'm Daniala Weir. I'm an assistant professor in the Division of Pharmacoepidemiology and Clinical Pharmacology, and I'm going to be teaching you all about randomized controlled trials today. So typically, when we are going to be conducting a randomized controlled trial, we started with a hypothesis, which is an idea about the medication that we might be studying, our new chemical compound. So, for example, this could be something like we think that new drug X might improve survival among patients with pancreatic cancer. So that's our hypothesis about the medication that we're studying. So the null hypothesis in this situation would be that the medication has no effect on survival. And then the alternative hypothesis for this would be that the medication increases survival. Medication X or drug X increases survival. So as I said, we always start off with a hypothesis as to how our particular medication or new chemical compound might be working. So then we move on to our research question, which is related to our hypothesis and is based on our hypothesis about how a new medication might work, but it's slightly different. So it takes on a format called PICO or PICOT. And this is based on the research question, including the population that you're studying, the intervention, and by intervention, I mean what the new chemical compound is that you're studying, the comparator. So this could be what you're comparing the new chemical compound to. So this could either be a placebo or an active comparator, like a new medication or another medication, which is for the same indication as the intervention or new chemical compound that you're studying. The outcome. So in our previous example, we talked about survival, but it's any outcome we want to look at. So typically, if it's an efficacy outcome, recall back to our previous study, efficacy is all about whether the medication or new compound works to treat the disease that we want it to treat. So, for example, if we're looking at our Vioxx or rofecoxib example, our outcome could be pain because it was used to treat pain in patients with osteoarthritis. So pain relief or a decrease in pain could be the outcome of interest. And time. So time is just the time period over which you're doing your study. So if we refer back to our Phase III RCT section in the drug life cycle, we talked about those studies can take, 2 to 4 years to complete. So our time period would just be how long the study is going to run for. So overall, we can ask our research question using these different components. So your research question would be, or an example of a research question could be, among patients with disease X, is there an increased risk of outcome Y among those taking the intervention compared to those taking the comparator over a 2-year period? So just remember, we start up all of our randomized controlled trials with a hypothesis and a research question, and then we move forward to determine how to analyze and conduct a randomized controlled trial in order to answer that particular research question, and then have an idea as to whether our hypothesis was correct or not. So I'm going to start off with a little bit of a motivating example, going back to our rofecoxib example from the previous lecture. So again, rofecoxib was a COX-2 inhibitor, and it was used, I believe, predominantly in conditions like rheumatoid or osteoarthritis to relieve pain and inflammation in the joints. So this is an example of a Phase III randomized controlled trial for this particular medication. It looked at the efficacy and tolerability of the COX-2 inhibitor rofecoxib, which is the study medication, versus or compared to ibuprofen in patients with osteoarthritis. So if we look at this particular example, COX-2 inhibitor is going to be our intervention, if we're thinking back to our PICO question. Ibuprofen is the comparator, and in patients with osteoarthritis is the patient population we're looking at, and we can't tell what time period we're looking at here yet. So this is another example of a randomized controlled trial that was conducted with the medication rofecoxib. So this was more of a safety RCT because it looked at upper gastrointestinal toxicity. So as you recall back, efficacy of these medications is typically measured when you look at pain or something like that. But here we're looking at a safety outcome. So we want to make sure that this medication isn't associated with a higher risk of upper GI toxicity compared to another medication, naproxen, which is used to treat pain in patients with rheumatoid arthritis. So in this example, we don't have a placebo as the comparison. We have an active comparator, which is naproxen. Naproxen is used for pain and inflammation treatment in patients with rheumatoid arthritis. So it's something that's used for a similar indication. So those were just two examples of randomized controlled trials that were conducted using rofecoxib as a new study medication. So again, going back to our hypothesis and our study question, how do we test our hypothesis or answer our study question? Well, we have to conduct an experiment. And I'm sure you've heard a little bit about experiments in a previous lecture and just the general outline and conduct of an experiment. And a randomized controlled trial is just a type of experiment where we give one group of patients a medication, and then we give another group of patients doesn't receive that particular medication we're studying. And then we compare the outcome between the two groups to answer our study question. And then that is going to provide evidence that supports or rejects our hypothesis. So again, just summarizing why we conduct randomized controlled trials in the first place and what they're meant to answer. They're just they're an experiment essentially, and they're just done in human beings. So that's just a general overview of hypotheses and research questions and some examples of RCTs related to rofecoxib. So then, of course, we have to, the next question is, well, how do we design a phase 3 randomized controlled trial to test our hypothesis and answer our study question? And that's what I'm going to get into in the next few slides here, is related to the proper conduct of a randomized controlled trial. So one of the key distinguishing features of randomized controlled trials includes random allocation of participants to a treatment arm. So we have an entire group of patients, and we're going to assess them for eligibility, because typically we only conduct a randomized controlled trial in a particular patient population. We're going to randomize them to one group or another, and then one group receives the intervention, and then one group allocated to another intervention, they receive another intervention. So this could be the placebo group, and then both groups are followed forward in time in order to see whether or not they've experienced the outcome of interest, and then the two groups are analyzed. So that's kind of one of the first and most important distinguishing features of a randomized controlled trial. Typically in an RCT, there's a placebo arm, which is typically an inert medication or substance that doesn't contain the active ingredient of interest. So that's usually the comparator group, or you have a standard treatment group as the comparator, which again is another medication on the market with a similar or the same indication for treatment as the new study medication. And then the third distinguishing feature of a randomized controlled trial includes blinding patients and clinicians. This is really important because we don't want the patients or the clinicians to know whether or not they're in the a particular patient is in the intervention group or the control group. So blinding is another really important feature of an RCT. So we're going to go into each of these features separately. So randomization is, it essentially just means that each participant that's eligible for a study or is included in a randomized controlled trial eligible patient population has a defined probability of being assigned to the control arm or the intervention arm of the trial. So this means that allocation is not determined by the investigator for the trial, clinicians, or participants, or patient characteristics at all. Allocation is not predictable based on a particular pattern. It's random. So each individual in a study has a 50% chance of being in the intervention group or 50% chance of being in the control group. Essentially, you have to think of it as a coin toss. It's either heads or tails. That's the probability that a given individual is going to be in the intervention or the control group. So why do we randomize in the first place? Why is that one of the key features of an RCT, and what do we achieve by randomization? Well, the most important reason that we randomize patients is so that we have comparable groups. So this means that factors extraneous to the relation of interest or confounders are equally distributed among the various arms. So this is just a fancy way of saying all of the characteristics of the characteristics of the intervention group are going to be the same as the characteristics of the control group. So for example, if we look at like the average age, in the intervention group, we want that average age to be the same in the control group as well. And we also want to see equal proportions of men and women in both the intervention and control group. And for example, if we're looking at a cardiovascular, a medication to treat cardiovascular disease, we'd want to see equal proportions of individuals with stroke, for example, between the intervention and control groups. So when I mean confounders, these are just potential, these are patient characteristics that we don't want to differ between the intervention and control groups. So we want them to be the same. We need the two groups to be comparable. Even if we do randomize patients, can we count on confounding never being a problem in a randomized controlled trial? The answer to this is no. Randomization only works on large numbers, meaning you have to have a large group of patients in order to make sure that patient characteristics are equally distributed between the two groups. And a lot of smaller trials can have imbalanced factors or patient characteristics just by chance. So again, when I mean confounding here, I'm talking about confounders. Confounding means that there's an unequal distribution of patient characteristics between the intervention and control groups. And confounder is just right now, it's just another word for a patient characteristic, which might be related to the particular outcome that we're studying. So for example, again, if we're looking at one of our outcomes is occurrence of cardiovascular disease or the occurrence of a stroke, then we want to make sure that the average age between the intervention and control group is the same, since age is a risk factor for the occurrence of a stroke. So we would have confounding if, for example, the average age in the intervention group was 40 years of age and the average age in the control group was something like 65 years of age. Age is a confounder, and because there's an unequal distribution of age or patients of a younger and older age between the intervention and control groups, then confounding is occurring. So there's different types of randomization. There's simple randomization, which I mentioned previously is just analogous to a coin toss. There's restricted randomization or blocking. So blocking or restricted randomization is when we assign groups of patients to the treatment or the control group according to a particular confounder. So we randomize individuals according to whether they're smokers or not, for example, and this helps to ensure that important confounders are balanced between the treatment and control group. There's also stratified randomization. So this is a little bit different. So you construct a strata. So you have a group of individuals who are smokers, for example, and another group of individuals who are not smokers, for example, and then you randomize within each group. So again, here's another example. You randomize treatment separately in those with pre-existing heart failure and those without. So people get really confused about the difference between restricted randomization and stratified randomization, but all you need to know is that in restricted randomization, you just have a big group of like 4 individuals who are smokers, and then you assign them to the intervention group, or you randomize them to the intervention group. And then you have another group of 4 patients who are non-smokers, and then you randomize them to the, or they are randomized to the control group. In stratified randomization, you start off with a group of all the smokers and a group of all the non-smokers, and then you randomize within each of the groups. So those are the main differences between the 2 types of randomization. So there's different units that can be randomized. So we can randomize individual patients, but we can also randomize groups. And these are typically referred to as cluster randomized trials. And by groups, I mean things like schools. You can randomize a school to a particular intervention, a hospital unit, or a community. These aren't typically done in randomized controlled trials of medications, but I've done a few studies looking at medication management applications or medication reconciliation software where the unit of analysis was a hospital because one hospital unit received the intervention, and then another hospital unit did not. They were in the control group. So that's what I mean by how groups can be randomized in the context of a cluster randomized trial. So allocation concealment is another very important aspect of good randomized controlled trial conduct. So allocation concealment is all about whether or not randomization was concealed. So this means that if allocation concealment is present, this is going to shield or those involved in a trial from knowing an upcoming treatment assignment for a patient. So if a clinician's part of a trial, they shouldn't know whether the next patient is going to be part of the intervention group or the control group if allocation is concealed. So if allocation concealment does not occur, this means that investigators and patients can then change who gets the next treatment assignment, which makes comparison groups less equivalent. So it ruins the balancing effect of randomization with respect to making the intervention and control groups equal in patient characteristics. So an example of this could be a trial investigator could read an allocation list and then enroll high-risk patients if they know that they would be allocated to the treatment group. So this means the intervention and control groups would not be balanced with respect to characteristics because only high-risk patients were allocated to the intervention group, and that's not what we want. We want to make sure that allocation is concealed and randomization is concealed so that randomization is maintained at the beginning of the study. So for this reason, this is why randomization is usually done remotely from an independent center, and that keeps the allocation concealed. It can also be done using things like sequentially numbered, sealed like envelopes, or numbered pill bottles prepared by a pharmacist so that they don't know whether the next patient is going to be getting the intervention or the control group. So allocation concealment is very important in a randomized controlled trial because it maintains randomization, meaning that the 2 groups, the intervention and control groups, will remain comparable with respect to patient characteristics or confounders. So why do we include a control group in the first place? So this is very important to understand. We include a control group because it minimizes the effect of minimizes something called the Hawthorne effect. So we know that just by virtue of being studied, patient behavior changes, which can improve prognosis, which has nothing to do with the treatment being studied. So that's why you include a control group. If you know you're being part of a study and the study medication is, related to treating something like osteoarthritis, then if a patient is being studied, they might, exercise differently or act differently in a way that can affect their symptoms. So if you exercise more, something like osteoarthritis might actually improve, or your symptoms might improve, even if you're in the control group. It has nothing to do with the study medication. It just so happens that your symptoms, the symptoms, which are the outcome of the randomized control trial, are improving because a patient's exercising more, just because they know they're part of a study. So that's essentially why we include a control group. You still have to give a placebo to a control group, though, because if you're not in the situation where you have an active comparator for your medication, and this is because the placebo effect typically goes beyond the Hawthorne effect, which is, just by virtue of being studied, you're gonna act differently. It's important to give a pill or a sham intervention with a potential affected result, because it still provides like psychological effects to the patient, even if the placebo is inert. So again, you give a placebo because it's supposed to achieve comparability of effects. So I think that everybody here has heard of something called the placebo effect, that, just because in your mind you think that something's going to have an effect, it actually does have an effect. So, if you're, I don't know, taking probiotics or something to treat, gastrointestinal symptoms, sometimes just the belief or thought that the probiotics are going to improve your symptoms will improve your symptoms, but they may or may not work. So that's why we include something called we include a comparison group, a control group, or treat individuals with a placebo, because we want to minimize the effect that the placebo. We want to minimize the placebo effect within our trial. That, just because we're being studied or we think that something might have an impact, we want to be able to include that in the control group, so we can achieve the comparability of effects between the intervention and the control group. But it's important to point out that not all placebos are created equally. So placebo responses are actually very complex. So, and this can occur with respect to more subjective outcome measures, such as pain, depression, or Parkinson's disease. So they've actually done studies that show that the perceived dose, cost, or color of a placebo can elicit an amplified response. So if a patient has, thinks they're getting double the dose, the placebo is more expensive, or they're taking a red pill rather than a blue pill, even if it's a placebo, they report lower levels of pain, depression, or Parkinson's symptoms, just because they think that the characteristics of a placebo are different, and the perception of whether or not the placebo is going to work actually increases if you are taking something that's more expensive or have a red pill. So that's very interesting. And again, another reason why we have a control group and are very careful about how we treat patients in that group. So another important characteristic related to randomized controlled trials is blinding. So after patients are randomized and the allocation is concealed, blinding essentially means that as the study is progressing, participants, clinicians, and investigators, assessors, or analysts don't know which group the patient is in. So whether they're in the intervention group or the control group. So in a single blind trial, this typically means that the participants or the investigators assessing the outcome don't know the treatment assignments. A double-blind study means that there's two groups who don't know what the treatment assignment is. This is usually the participants and the outcome assessors or the investigators. And if a study is triple or quadruple blinded, this means that 3 or 4 of the relevant groups that are part of the conduct of the trial are not aware of the treatment assignment. So why do we blind in the first place? So we know that subjects that are given the active drug might report their outcomes differently or change their behaviors if they know that that's the group that they're in. And similarly, those who know that they got the placebo might leave the trial, and blinded subjects are more likely to comply. So, for example, if you're able to know that you're given an HIV vaccine, if you're in a trial for an HIV vaccine and you know that you're in the intervention group, like you know you've gotten the HIV vaccine versus a placebo injection, you could actually increase your sexual activity because you think you're protected. You know, it's also important to blind study personnel because they might transfer their inclinations or attitudes to patients and adjust the dosage of the medication. So if a patient is in the intervention group and maybe it's not working quite well enough, like a clinician might increase the dose for a patient to see if it might work better. We blind assessors because they can unconsciously bias their outcome assessment. So if an outcome assessor knows that a patient's in the intervention group for an RCT of a new pain medication, they might actually, you know, ask different questions about a patient's pain. They might probe them differently, and they might also like report their pain scale a bit differently. And we also blind data analysts because they could unconsciously look for specific patterns in the data when they're actually analyzing the outcome data as a result of the study. So that's why we blind individuals in the study, including subjects, study personnel, assessors, and data analysts, because we want to keep everything as objective as we possibly can between the two groups. So there's an important distinction between blinding and allocation concealment, and students get a little bit confused about this, but it's important to remember that the concealment of allocation is a procedure to protect randomization before the subject answers the study or the trial. So there can be failed concealment from the investigator or the clinician, and failed concealment from the patient perspective. But it's important to point out that concealment of allocation is always feasible. There's no reason that a clinician or an investigator or a patient needs to know whether the next patient being enrolled in the trial will be part of the intervention or control group. And if concealment allocation or allocation concealment is not done, this can result in selection bias, which means that randomization benefits are lost and treatment assignment is no longer random. And we might have differences in patient characteristics between the intervention and control group, which makes it so that they're not comparable. The treatment group and the control group are no longer similar with respect to important patient characteristics or confounders. Blinding, on the other hand, is the masking of the treatment group after randomization has occurred or once the trial has begun. So this like failed masking of patients, investigators, and outcome assessors can happen when blinding isn't always feasible. So in a lot of situations, depending on the intervention that you're actually looking at, blinding might not be really possible. So if it's something like a lifestyle intervention where the patient's getting like really specific counseling, or they're getting like an app or something like that, then it's really difficult to blind the patients because they kind of already know that they must be in the appropriate group, or that they're in an intervention group. But it's important to point out that if blinding isn't done, this can result in patients biasing their responses because they know what treatment group they're in. And it can also lead to biased outcome assessment because the investigators also know what treatment they're in. So allocation concealment is always possible. And it's really important to ensure that the intervention and control groups start off very similarly at the start of the study. But blinding is the masking of the treatment after randomization occurs or after the study's already started. And again, depending on the nature of the intervention itself, it may or may not always be feasible or possible to blind individuals. So just a quick note on the feasibility and ethics in randomized controlled trials. So you're going to get into this a lot more in other lectures related to scientific integrity, and I think you're going to get another ethics lecture from a clinical specialist who looks like at ethics and RCT. So this is just a quick primer for this. But we have to start thinking about, situations when it's not feasible to conduct a randomized controlled trial and when it might be unethical to randomize an individual to treatment. And, how do we study a treatment if it's unethical to conduct an RCT? So typically, it's not really feasible to conduct an RCT when you there isn't clinical equipoise with respect to a particular medication. So clinical equipoise means that there's genuine uncertainty with respect to whether one medication is better than another medication. So, if you have a clear, you have an idea that a particular medication might be better or worse, or have better efficacy or worse safety compared to another medication on the market, it wouldn't be particularly ethical to conduct a randomized controlled trial in that particular situation. It's not always feasible to conduct a randomized controlled trial in situations where, for example, you're looking at a outcome such as cancer. So sometimes, if the cancer takes a really long time to develop, then it's maybe not always ethical in order to look at a safety outcome such as cancer, because you might be, waiting 15 to 20 years for a particular medication or a particular trial to be completed. So that's related to the feasibility of a randomized controlled trial. So then we have to think about, how do we study a treatment if it's unethical to conduct an RCT? And we're going to get into that later in the course. We might have to look at a few other options, because it's not always possible to conduct an RCT for a particular treatment. So just to give a quick example, in patients who have very limited life expectancy, who might be very frail, who might be very elderly with lots of different chronic conditions, it's not always ethical or feasible to conduct a randomized controlled trial in these patients. So that's another situation where we might have to conduct a different type of study in order to answer questions of effectiveness and feasibility related to a particular treatment. So now we're going to move on to the classification of randomized controlled trials. So we can look at something called a two-arm parallel trial. So essentially, this is the simplest example of study design in an RCT. So we just start off with our study population. We define our study population we want to study. We have a sample that's enrolled in the study, and then we randomize them to either the treatment group or the placebo group. And then we follow them forward in time to see whether they develop the disease or outcome of interest, or don't develop the disease or outcome of interest. So that's a very simple example of a two-arm parallel trial. The next type of RCT study design is called a factorial design. So again, we start off with our population, then we have a sample, in our population. But in this case, we're testing multiple combinations of different placebo and drug combinations. So in the first group, we might actually be interested to see whether there's an interaction between drug A and drug B. So we might give one group, a combination of the two, then follow them forward in time to see whether they experience the outcome of interest or not. And then another group, they might just get drug A and placebo B. Another group, they might get placebo A and drug B. And then in the last group, they're going to get placebo A and B. So we're really able to, specifically look at the effects of drug A on its own, drug B on its own, and then the combination of drug A and drug B. And we're able to do this through the different treatment groups and then assignment of the different placebos. So that's a more complicated study design, but it's a little bit more interesting because we're actually looking at two active interventions within one trial and not just one. So it can actually be a little bit more efficient depending on the types of medications that you're studying. So this is just an example of a factorial design for a randomized controlled trial. So in this particular example, they looked at a combination of vitamin C, E, and beta carotene for the secondary prevention of cardiovascular disease or cardiovascular events in women. So we have more than one intervention in a factorial design. So I talked about this a little bit earlier, I think. I certainly talked about efficacy, but we have to distinguish between trials of efficacy and trials of effectiveness. So in the situation where we're looking at effectiveness or efficacy studies, what we're doing is we're really looking to see whether or not a particular treatment works under ideal circumstances. So whether it treats the disease that the medication's intended to be indicated for the treatment of. So efficacy is, under very ideal controlled circumstances, does a particular medication work? And studies of effectiveness are a little bit more different because these are typically done in more of a real world clinical setting and everyday clinical practice with maybe a group of patients who are more generalizable to the study population that would actually be receiving this treatment. So it's a little bit less of a controlled environment where, patients are being monitored by the clinical staff that they would be seeing in more real world clinical practice. And it's not necessarily like the most ideal controlled setting as compared to a clinical trial of efficacy. So there's a little bit more generalizability of the study findings in an effectiveness trial, but in an efficacy trial, because it's such a controlled environment, the internal validity of that particular study might be better. So, things like loss to follow-up or, unblinding of patients can happen more often in clinical trials that are related to effectiveness, whereas we can control these types of things a little bit better in clinical trials of efficacy. So again, efficacy is all about, if a medication is taken, does the treatment have an effect? And then clinical trials of effectiveness really study whether or not the treatment will have a good result in patients if it's offered to patients. So this means that you take into account, tolerability and harmful effects of the medication, because if a patient takes a medication and they experience an adverse effect, they're not going to be adherent to the medication. So that's more captured in studies of or clinical trials of effectiveness. So just to give a few examples of trials that are specifically looking at efficacy and those that are specifically looking at effectiveness. So this particular study looked at the efficacy of a HIV vaccine to prevent or is preventative against HIV. So this is just the background here. So in the methods section, we can see that the patients received either the vaccine, the new vaccine that was under study, and then the placebo. And then they specifically looked at whether or not the individuals were diagnosed or infected with HIV after they received the vaccine. So they looked at viral load and the DNA expression, I think, of the HIV infection. So their overall conclusion for the study was that the particular HIV vaccine did not reduce either the rate of HIV infection or the viral load within their particular patient population. So that's an example of a trial that looked at the efficacy of a HIV vaccine. So this is another study or randomized controlled trial, but it specifically looked at the effectiveness of a vaccine. So this was a vaccine against typhoid. So in this study, they conducted an effectiveness trial where residents of India who were over the age of 2 were randomly assigned to receive a single dose of this typhoid vaccine or an inactivated Hep A vaccine according to different geographic clusters, and they had different clusters within the studies group. And so what they found was when they just offered this vaccine in different groups, that it was effective in young children and protected unvaccinated neighbors of the areas that received the particular vaccine. So this study took into account direct and indirect protection of the vaccine. So again, this was related to effectiveness, and the previous one was related to efficacy. Efficacy, does the medication work to treat the disease it's meant to treat? And then effectiveness is if a medication or a vaccine is offered to a group of individuals or an individual, is it actually going to have a positive effect in the real world setting, not a well-controlled clinical setting. So another type of randomized controlled trial they're called superiority and non-inferiority trials. They're also called active comparator trials. So this kind of gets into the situation or addresses the situation where there might be, there's many medications on the market or effective medications on the market to treat a particular disease or condition. Use of placebos probably isn't ethical. If we know that there's something that can treat a particular disease a patient has, we can't just give them placebo or nothing. We actually have to give them the active comparator. So that's the situation where we conduct a superiority or non-inferiority trial. And we're trying to answer the question whether or not a new drug is actually similar to or better than another drug on the market. So again, yeah, clinicians probably don't care that the new drug that we're studying is better than placebo. They care if the new drug is similar to or better than something that they're currently using. So a superiority trial aims to determine whether drug X is better than drug Y, which is currently on the market, by more than some pre-specified margin. So that can be very difficult to demonstrate, and it requires a very large sample size. Whereas non-inferiority trials intend to show that the effective drug Y or drug X is not worse than the active comparator Y by more than some pre-specified margin. And so that's typically a little bit easier to demonstrate and requires a smaller sample size. So another example of a study design in RCTs is the crossover RCT. So in this particular situation, we start off again with our study sample based on our pre-specified study population. We randomize individuals to receive either placebo or treatment. And then after that, a certain period of time, we're going to measure their outcomes. Then we remove the treatment for both groups, and we allow for a washout period, which is meant to remove any of the effects of the medication for a certain period of time. And then we give the patient the treatment if they were in the placebo group initially, and then or we give the other individual the placebo if they're in the treatment group, and then we measure outcomes after that. So in these particular situations, we actually compare patients within themselves. So this is one single patient, and we'll compare outcomes after treatment with the placebo to outcomes after treatment with the particular intervention. And same thing for this patient. We would make the same comparisons. And this is a nice type of study design because we're able to, there's no confounding or differences in patient characteristics between the study groups or risk of that happening because we're making the comparison within a single patient. So some of the assumptions for this crossover RCT design is that the treatment has a acute effect, not a chronic effect, so that after you stop taking the treatment and you instigate the washout period, there's not actually going to be any lasting effect of the medication after that period. So it's specific to those types of medications, and you also need to fulfill the assumption that a patient doesn't change that much with respect to their characteristics over the study period, or otherwise there would be confounding according to time. So that's another study design that you can look at for randomized controlled trials.